Hello to everybody. I welcome everybody of you. My name is Patrick Meybohm. I'm working as an anesthetist and intensivist at the University Hospital in Würzburg in Germany. And I'm really happy to talk today about bleeding management and patient blood management and the implementation of PBM in clinical routine. So this workshop is supported by HemoSonics. So these are my conflicts, and a lot of companies are supporting the initiative of patient blood management in Germany. So in clinical routine, we have at least three major problems and issues. So we have the problem and the risk of anemia, and that's the reason why we really should have an eye on patients with too low hemoglobin levels before surgery and to improve anemia management. We also have the issue and the risk of blood loss and bleeding and the bleeding associated complications. And of course, one of the main principles to treat patients with anemia or bleeding is RBC transfusion. But as most of you know, transfusion is associated with a lot of risk factors too. So we have really a complex situation where we need new strategies to solve these issues and these problems. And in most of our hospitals, it's really easy and it's cheap, and we are coming to use red blood cell units from donors. And we use millions of RBC units worldwide, and it's a perfect system. So on the one side, we have millions of donors, and on the other side, we have a lot of patients consuming these RBC transfusion. But as I said, alternatives are really urgently needed to provide a better care for our patients. And here you see some examples of patient blood management programs worldwide. So the United States, UK, and Australia, they are already providing PBM programs instead of any guidelines about the safe transfusion medicine. So it's more that the patient is in the middle of our program, of our therapy, and we really need to keep an eye on hemoglobin levels, on anemia, on bleeding, on blood sparing techniques, and on the right indication for red blood cell units, transfusion, and all the other blood products that need to be transfused. I'm coming back to patients with low hemoglobin levels and anemia, and it's quite important to get an impression how often does this happen. Worldwide, we see more than 300 million people undergoing any surgical procedures, and we know that about 30% of these patients have lower hemoglobin levels. They are suffering from anemia. So we are talking about 70 to 100 million patients each year undergoing surgery, although hemoglobin is too low and these patients are suffering from anemia, and we need more therapeutic approaches instead of just RBC unit transfusions. So what is important in the field of management of pre-op anemia? And what about the screening and the treatment of these patients? I mean, it's so easy. We know that a lot of patients with anemia are suffering from iron deficiency. And this is easy because we have other medical drugs to substitute and to help these patients with iron substitutions. So in terms of pre-op anemia management, you just need to find the right patient, and then you should do the right diagnostic and give the patient the right therapeutic approach. What you can see here, the time of surgical procedure and the time before surgery, that is called pre-op phase, and the time after surgery. And a lot of patients planned for surgical procedures, they might have a lower hemoglobin level before surgery. And at the time point of surgical procedure, hemoglobin is going down and physicians just transfuse RBC units. And in terms of pre-op anemia management, it's really important to find the patient who might benefit from a pre-op optimization approach. For example, IV iron substitution to improve erythropoiesis, to increase hemoglobin levels under surgical procedure. And then you will have a hemoglobin drop during surgery, but in a way that there's no need for any RBC transfusion. And now I'm coming back to probably the most important part of patient blood management. This refers to the topic and to measures and to techniques. How could we minimize, how could we reduce or avoid any unnecessary blood loss? How could we manage bleeding complications? And here we need to talk about any blood sparing techniques. We need to talk hemostasis, we need to talk about intraoperative blood salvage, and of course we need to talk about coagulation diagnostic and coagulation management. And here really we need to keep an eye on every single red blood cell to minimize and to avoid any unnecessary blood loss. So in terms of blood sampling for central lab, most of our colleagues and most of hospitals just use the big tubes sampling blood for analysis, for red blood cell count, for liver enzymes, for renal parameters, or for inflammation. And in most of hospitals, you need different colors for different techniques and different data. But as you can see here, most of these tubes are a big tube, and here you probably have 5 or 10 milliliters of blood loss. And probably in the future, we should keep an eye on blood sparing techniques, and we should probably reduce the size of these tubes to avoid unnecessary blood loss. And this can easily be done. What you can see here, different types of tubes where you have roughly the same size for the computer and for the analytics, but in the tube you see it's really easy to reduce the amount of blood. It's just that you need some little changes, and thereby you can really reduce blood loss for blood sampling by roughly 50%. And this is really important as patients on an intensive care unit, they really lose a lot of blood during their stay. So about 2 weeks on an ICU, you lose about 500 milliliters. And about 2 months on an ICU, you lose 5 liters. So here you see it's really important to reduce blood loss by blood sampling, and also to think about how could we avoid unnecessary blood loss. And of course, in the surgical field, we have a lot of patients with major surgery in vascular surgery, cardiac surgery, or even in cancer surgery or orthopedic surgery. We have blood loss during surgery. And there are 2 ways. You can just skip the blood in the bin, and there you have blood wastage, or you just collect the blood of the patient. You just give some heparin to this blood, and then you use a machine that is called cell saver machine. You wash patients' blood, and then thereby you can produce a red blood cell concentrate and just give it back to the patient. So hereby you can also reduce unnecessary allogenic blood transfusion. And also, if in a situation where you have a patient with coagulopathy, with unknown bleeding or trend to bleed, you really need to think about what could be done in terms of hemostatic products. What could be done by the team in the OR, by the surgeon, by the nurses, or by the anesthetist? What could be done to improve platelet plug formation, to improve fibrin network formation, in terms of diffuse coagulopathy that is probably surgical related. And here you see a summary of different companies, different products, and all of them are improving coagulation situation in the surgical field. And these are also a main principle in terms of blood sparing techniques. And also, at least in the situation of any unexpected or unknown and unexplained bleeding situation or supposed coagulopathy, you really need to think about what is the underlying problem of the coagulopathy and of the bleeding. And of course, we need to ask the surgeon to control any surgical related bleeding situation. We need to control temperature and calcium and pH. We need to ask for any drug history and any anticoagulant. Also, we need to think about anti-fibrinolytic agent. We need to talk about tranexamic acid. And of course, we need to think about to administer coagulation concentrates or coagulation factors. But importantly, you need a diagnosis. You need principles or you need devices, techniques to diagnose an underlying coagulopathy, and then you need to think about the therapeutic approach. Now, here you see a summary of the different measures containing to the patient blood management and blood sparing techniques principles. So we need to think about the number of blood sampling, the tube size, the cell salvage device, the diagnosis of any coagulopathy. And here you see different companies are providing different devices, and all of them are able to give you an impression and a detailed picture of the patient, what is probably the underlying problem and what should be treated and corrected. And also we need to think about non-invasive measurement of some parameters and monitoring of anticoagulation. And of course, we see a lot of patients with any bleeding that is associated to any anticoagulants. So again, here we need a fast diagnostic, a patient fast or patient-related diagnostic, and then the treatment. But of course, at least in patients with major bleeding, we need to think about what might be the correct indication for blood transfusion and what is the correct transfusion trigger. And most hospitals and centers, they are using a single unit policy. So you check hemoglobin levels, and then you ask for RBC unit and you transfuse, and then again you re-evaluate and recheck hemoglobin levels. And in our country, a lot of hospitals are using transfusion trigger checklists where they ask for the indication for symptoms to indicate, to document. And this could be a way to standardize transfusion triggers too. I talked about a lot of issues. I talked about anemia management, about blood sparing techniques, coagulation, monitoring and management, and also transfusion triggers. And a lot of hospitals, they have really difficulties to implement a patient blood management concept. And this was the reason where we thought about if a checklist could help hospitals to improve the infrastructure, to define pathways for a patient, and to bring the PBM concept to the patient. And here you see some screenshots in terms of PBM project management, in terms of what should be done to improve anemia management, what should be done to improve coagulopathy management, to improve any blood sparing techniques and modalities and techniques and bring them to the patient, and also about what should be done to improve a patient-centered decision making too, and also about key performance indicators. So here we have more than 100 issues, items, where at least German hospitals have it more easier to implement PBM implementation. And from a scientific point of view, we already know that patient blood management is beneficial for our patient. And a lot of PBM initiatives have been done worldwide. And here, a colleague of mine has summarized all the available literature and evidence and provided a systematic review and meta-analysis of all the worldwide PBM studies, and all of them were focusing on pre-op hemoglobin optimization, on blood sparing techniques, including coagulation monitoring and coagulation management, including transfusion protocols. And we found 17 PBM trials from Europe, from United States, from Australia. And here you see the impressive results. So the successful implementation of patient blood management is able to reduce the need for RBC transfusion by roughly 40%. Implementation of PBM is probably also able to reduce complication rate in surgical patients, and PBM is probably able to reduce mortality rate. And again, these data, these results are really impressive. Probably there's no other drug or no other single device that is able to reduce transfusion need, to reduce complication. It's the whole concept, including the pre-op optimization, to keep an eye on blood sparing techniques, to keep an eye on coagulation management and treatment, and to keep an eye on what is the right indication for your patient. Now I've finished. Thank you very much for your attention.